Welcome everyone. We're just going to take a minute for everybody to digitally file into our virtual auditorium, and then we will start the event. All right, I think enough people have joined us. Welcome everyone. My name is Carmela Shachar, and I'm the Executive Director of the Petrie-Flom Center for Health Law, Policy, Biotechnology, and Bioethics at Harvard Law School. We're here today to discuss advanced care planning in the age of COVID, lessons learned, and policy implications. This is an event that the Petrie-Flom Center is putting on as part of the Project on Advanced Care and Health Policy, which is a collaboration between the Petrie-Flom Center as well as the Coalition to Transform Advanced Care, or CTAC, which is a nonpartisan, nonprofit alliance of over 150 national organizations dedicated to being a catalyst to change the health delivery system, empower consumers, enhance provider capacity, and improve public and private policies in advanced illness care. I think this conversation is incredibly timely because I think that COVID-19 has really shown us a lot of the strengths and weaknesses of our healthcare system, and certainly has laid bare gaps in advanced care planning, as well as the barriers that persist despite many years of advocates working hard to promote advanced care planning. Some of that will be discussed in today's conversation. Before I kick it off to our panelists, I just want to say a few housekeeping words. First of all, if this is your first Petrie-Flom event, welcome. We keep a very robust event calendar. If you are interested in other of our events, which I hope you are, please go to our website and sign up for our newsletter. It comes out twice a month. We hold ourselves very strictly to that standard. And that means that you can attend great events such as, or one last week, how to run a hospital in the midst of a pandemic, or the one that we're going to run next week on June Medical, the recent abortion case announced by the Supreme Court, as well as considering the impact that COVID is having on reproductive rights in the US, which will then be followed up by a panel on reproductive rights in the time of COVID in Latin America and across the world. So a lot of interesting things. I also want to mention that CTAC is no slouch. They're also bringing you virtual programming. What I'm really excited about is their summit that is going to happen, I believe, on October 27th through 30th this year. So, as you prepare your Halloween costume, also get excited for the summit. And if you go to visit CTAC's website, I'm sure you can find more information about that. In the meantime, you're here for this event. Part of this event will have a moderated discussion that will incorporate some of your questions. How do you ask questions? You might be asking, that's your first question. Here are some ways to ask and some ways not to ask questions. Please don't try to use the chat. The chat will not be monitored. Please don't use the handy little blue hand raise feature. That also will not be moderated. If you would like to ask a question, you can do so in two ways. If you go to the bottom of your screen, there is a Q&A button. And if you click the Q&A button, you will be able to submit a question that way, and we will be monitoring that. The other way you can do it is by going to Twitter and joining us in the conversation on this event by using the hashtag ACPCOVID. Again, that's ACPCOVID. We're really looking forward to your questions. Speaking of which, I want to hand it over to our first speaker as well as moderator, Shoshana Ungerlater, who is a physician by training. She's the founder of the End Well Foundation, and she is physician and teaching faculty member of Sutter Health. And I can't think of a better way to have somebody guide us through this conversation. Shoshana, we're delighted to have you.
Thank you so much and welcome everyone. Thank you to the Petrie-Flom Center for hosting the conversation. And as Carmel mentioned, I'm Shoshana Ungerlater, an internal medicine physician in San Francisco and the founder and president of EndWell, which is a media platform and an annual conference focused on transforming serious illness and the end of life into a human-centered experience. So we're in quite a unique moment in time, to say the least. You know, the COVID pandemic has really shown us that life is fragile, that tomorrow is never a given, no matter how old you are, and has really shined a light on the hidden world of caregivers, both frontline healthcare workers and informal family caregivers, as well as loss and grief on a massive scale. And in particular, the pandemic has shown us the importance of clearly expressing our personal wishes for medical care in the setting of a serious illness or in an emergency. Advanced care planning, the topic of our discussion today, is something that I'd like to define. This is making decisions about the healthcare that you would want to receive if you're facing a medical crisis. So these are decisions that you have to make based on your personal values, your preferences and goals, and then subsequent discussions with the people that you love, as well as your healthcare professionals. Advanced care planning includes information on types of life-sustaining treatments, so the medical side of things, deciding which types of treatments you would or would not want should you be diagnosed with a life-limiting illness, sharing your personal values with your loved ones, and then completing an advance directive document to put into writing all of this information, as well as indicate who you choose to speak for you should you be unable to speak for yourself. Ideally, advanced care planning, this personal reflection and these conversations happen years upstream, years from an acute crisis. And then you want to revisit them annually as your personal circumstances change. It's important to point out that you're never too young to do this. So, you know, we must meet this unique moment that we're all in so that more people have these conversations to better ensure that they receive care that's in line with their goals and their values. There are so many opportunities for policymakers and policy stakeholders to make advanced care planning more accessible and raise the awareness of just how important these conversations are. And so with that, I will introduce our first panelist to kick things off. We have Stephanie Anderson, the Executive Director of Respecting Choices. Take it away, Stephanie.
Oh, thank you so much, Shoshana, and what a great tee up for the conversation today. And I would like to thank the Petrie-Flom Center and CTAC for hosting this event, and I'm so honored to participate. As Shoshana said, I'm the Executive Director of Respecting Choices. We work with communities and organizations to design and implement reliable and sustainable systems for advanced care planning. So these communities and organizations can make and ultimately keep a promise to those that they serve. And that promise is to know and honor individual preferences and decisions for healthcare. Following our transition from Gunderson Health System to CTAC Innovations, which is a nonprofit affiliate of CTAC, I had the pleasure of leading Respecting Choices through a reinvention process. We sought to build upon the strong foundation of best practices we developed while adapting to their specific environment, the concept of freedom within a framework. This means that being faithful to what we know works through our 25-year history of research and learning from those doing the work, advanced care planning, that created the framework, and customizing it to meet the needs of all people served by the organizations and the communities. That's the freedom and flexibility within the framework. And while we didn't know it at the time, it turns out that this concept was ideal preparation for what we are all facing with the pandemic. We continue to reinvent ourselves during this unprecedented time, which demands that we all of us innovate and improve to meet the challenges before us. So I was asked to speak to some of the challenges, what is not working, and set the stage from a historical perspective. One example that I wanted to bring forward is a policy with really good intent that has not achieved its laudable goal, the Patient Self-Determination Act. As implemented, its focus has been on completion of a written document rather than a conversation about what matters most. As a result, compliance was measured through a checkbox mentality, right? We ask people if they have an advance directive, we provide them a handout with some information, and if they give us one, we put it into our medical record. I'm not advocating that we eliminate this policy, but improve it. I want to be clear about that. There's opportunity for improvement. So let me talk about that a little bit. The historic focus with this policy has led to the misconception, and yes, I want to repeat that, a misconception that completion of a statutory advance directive is an end in and of itself. And Shoshana just so eloquently talked about the process that should culminate in completion of an advance directive. Clinical evidence and experience tells us that this is not good enough and just completing a document does not work. So we don't want to advocate to increase the number of individuals with a completed document and that being a sole solution. That will not work without a defined communication process and redesigning our system to support it. The system must be redesigned to include access to quality conversations that identify an individual's core values, accurate transfer of this information so a prepared decision maker can advocate for care or procedures that their loved one would or would not want, and preparation of the healthcare team to navigate the difference between all of what can be done in modern medicine to what should be done based on what matters most to that individual. COVID-19 has shined a spotlight on the critical importance and immediacy of having meaningful advanced care planning conversations. One organization worked collaboratively with 50 nursing homes, working with vulnerable, frail elders and their healthcare agents to proactively have advanced care planning conversations to clarify their goals should they contract COVID. The overwhelming reaction to this was relief. Yes, relief by asking these questions ahead of time, even if ahead of time meant hours or days, about what they would want and preparing their healthcare agents for a possible decision-making role. Clearly, they wanted our help. In addition, many younger, as Shoshana was saying, healthy adults are no longer feeling invincible as they're aware they may contract the virus. They realize that they need to plan now for their own care, who their decision maker will be, and what decisions they may be faced with. The younger population, the healthier population also wants our help. So one way that Respecting Choices has aimed to help is by offering a complimentary COVID-19 toolkit. The link to that toolkit is on the Petrie-Flom website, or you could go to respectingchoices.org. And the toolkit contains conversation guides for having these conversations, as well as materials for individuals and their healthcare agents to become better prepared. For all of us to collectively help together, we must remove these barriers to meaningful conversations. So I'll conclude by saying that I'm incredibly honored to have actively participated with colleagues in many, many national leadership conversations regarding these topics and potential solutions. And I'm really looking forward to hearing from some of these amazing colleagues today. Thanks everyone for listening to my remarks, and I look forward to your questions following my colleagues.
Thank you so much, Stephanie. And next up, we have Reverend Marilyn Barnes, the Vice President of Mission and Spiritual Care at AdvocateAuroraHealth.
Thank you, Shoshana. I'm grateful for the invitation to serve on this panel and participate in the conversation on advanced care planning. Thank you to CTAC and Petrie-Flom for their vision and commitment to equity and care. As a chaplain, when I was reflecting on this topic, I thought about the social determinants of health, where people live, work, receive their education, their social and community context, and their health and healthcare. All these contribute to a person's overall health. However, health and healthcare as a human right in this country is a broken system, and that includes advanced care planning. For persons who are underrepresented and disenfranchised, access to healthcare, the quality of healthcare, and trust of the healthcare system are 3 points of entry when it comes to advanced care planning disparities. If we look at access to healthcare, quality of care, and trust for African Americans and the healthcare system, there is a fractured foundation for advanced care planning to build on. Research informs that white physicians treat white patients differently from African American patients when it comes to level of pain, prescribing medications, and their perspective of medication compliance. There is the Tuskegee Experiment, where for 40 years, African American men were told they were receiving free health care from the government when they were actually being studied for untreated syphilis. Per a 2017 CDC report, African American babies have 2.3 times the infant mortality rate as compared to white babies, and African American mothers were 2.3 times more likely than white mothers to receive late or no prenatal care, regardless of their socioeconomic status. 2018 statistics show African Americans make up 13% of the US population, but 42% of new AIDS cases. Additionally, we know that African Americans experience high levels of being turned away for COVID-19 symptoms, and African American and Latinx persons received care when they were sicker than their white counterparts. In the midst of this COVID pandemic, we also know that Black and Brown people have higher prevalence of pre-existing conditions, such as cardiovascular disease and diabetes, and are disproportionately dying from COVID-19. With this history, when we as clinicians bring up the topic of advanced care planning, we are starting in a place of valid distrust. The actual advanced care planning process and resources generally require a higher level of education, English as a first language, and a trusting relationship with the clinician and the healthcare system. We cannot help align a person's care with their values if clinicians don't take the time to understand and know a person's values, acknowledge their own implicit bias, and work to check that bias at the door. Asking the questions, who do you trust? What medical interventions do you want? What medical interventions do you not want? Can cause anxiety in a person who trusts their clinician. Just imagine the level of anxiety and fear if there is not a trusting relationship. So how do we move forward? Is policy the answer? There are policies in place now, and my esteemed colleagues on this panel know all the details of them. Yet policy without accountability are just words on paper. We need clinicians to be held accountable for their implicit bias. We need clinicians in training to have implicit bias and anti-racism education built into their curriculum and simulations that they must pass to move forward to the next level. We need standards of practice around discrimination and accountability for behavior. Each patient is different, and we need equitable education, communication, and empowerment of patients in a safe and caring sites of care and communities, so they have the opportunity to speak their truth about what medical interventions they want and to say who they trust to honor their decisions if they are unable to speak for themselves. As you can tell, I am passionate about this topic, As a chaplain, I have been in numerous situations regarding advanced care planning, and it is very important that we integrate advanced care planning into the healthcare system's DNA. Thank you for the opportunity to speak, and I look forward to your questions.
Thank you, Marilyn. Everybody be sure to join the conversation on Twitter and ask your questions either via Twitter or through the Q&A function on Zoom below. So we'll be getting to answering your questions shortly here. But next up, I want to introduce Marion Grant, the Senior Regulatory Advisor at the Coalition to Transform Advanced Care and adjunct faculty at Johns Hopkins and the University of Maryland Schools of Nursing.
Thank you, Shoshana, and thank you, Petrie-Flom, and I guess thank you, CTAC, even though I work with them. So I'm going to do the wonk part now. Obviously, as a practicing nurse practitioner, I'm very aware of the importance clinically of advanced care planning, but the Petrie-Flom Center is a policy center, and so we want to get into the policy stuff. And I would say that COVID-19 has been an amazing policy experience, but now bear with me, because the government, the federal government, and I work on the federal level, the federal government has been amazingly responsive to needs that we all expressed once the pandemic really hit. One of the most important areas that they changed was telehealth. Now, I would remind some of you, because now, like we're all doing telehealth, it's like no big deal. Just a few months ago, you could only do telehealth if you physically got yourself to a federally qualified health center, a Medicare certified center, and then were on, interacting remotely with some healthcare provider. Because of the pandemic, everyone realized that was not a good idea, right? We did not want people coming in if they didn't have to come in, and yet we still needed to have important clinical interactions and conversations. So Medicare changed the rules and said, okay, you can do telehealth at home, and you can do advanced care planning via telehealth, which was high on our list at CTAC for things we were advocating for. But they actually, without too much prompting, they changed that. And that is important because you could argue that telehealth is convenient for all patients, but it is essential for people with serious illness. Even without a pandemic, making people have to leave their homes or wherever they are and physically come into a clinical environment, when that isn't essential, it just doesn't make sense. And we know that people often can't because of transportation or caregiver issues come in. So telehealth was a wonderful change because of COVID-19. Now, temporary during the pandemic, of course, the pandemic is being extended every few weeks, and we'll see how long this goes. But they changed that so we can do advanced care planning remotely. And the other thing that they changed, which was enormously important, is initially they said you could do telehealth only via video and audio interactions. So you could do it via a special portal that you got from your provider, or you could, then they said, okay, maybe Zoom is okay. And then, okay, FaceTime is all right, and Skype is all right. And then finally, we and other organizations said, wait a minute, we have patients who don't have computers. We have patients who don't have Wi-Fi. We have patients who don't have smartphones. We need to be able to talk to them in this pandemic. And they recognized that, and they said, okay, all right. So audio only for advanced care planning and other things is fine. We think that that is an enormous move in the right direction as an equity issue, right? You shouldn't have to be deprived of having an advanced care planning conversation because you don't have a smartphone. I mean, that's just crazy. So that was a temporary change. They have also said, you know what, we're going to pay the same for telehealth encounters that we pay for in-person encounters. And we all think that's a great idea that also probably needs to be continued. Because why make people come in for a conversation if it could be held effectively remotely via the phone or Skype? The second area that we're advocating for at CTAC, and we've had a little bit of movement on the part of the government, we're working on the rest of it, is right now only nurse practitioners, physician assistants, and physicians can be reimbursed for having advanced care planning conversations. Now that doesn't mean that other people don't have them. And it's not like we didn't have them because we had to be paid, but being paid for something in a busy clinical schedule is kind of important. And so CTAC is advocating that we expand the group of people who can be reimbursed for these conversations I think very appropriately, to clinical social workers who, oh, by the way, are trained to do this. And then we're also saying, okay, maybe not all nurses, although I would love all nurses, but maybe not all nurses, at least case managers who have ongoing contact with people and would be in a wonderful position. They already have a relationship. They could easily do advanced care planning the next time they interact with the client. The last area that we're advocating for is, right now, if you have an advanced care planning interaction and it's not part of your annual Medicare wellness visit, you're going to be charged a copay for it, or a deductible, or a cost sharing thing, because it's just like you are charged for any other medical intervention. And we don't think that makes sense. If you don't have to pay it for the annual visit, why do you have to pay it for any visit? And so we are working, and actually we heard just the other day that when we pointed this out to the federal government, they said, you mean you can't go, you have to, why? We thought we got rid of the copays. We're like, no, you didn't get rid of the copays. So we are working with them to try to remove the copays for interactions beyond the annual wellness visit. Now, all of this sounds great. It is all at the moment in the works or temporary during the pandemic. We are advocating that some of the things be permanent. But we also recognize that the government needs to kind of monitor, how is this going? And we think these things are a good idea, but we are running a federal experiment right now, a policy experiment. And we will have data on how many people did advanced care planning, what were the outcomes, who billed for those services, how often did they happen? And that will hopefully guide the government to making further decisions. The last thing I'll say is that there's an opportunity at the state level for policy changes as well. Most advanced directive documents require signatures and witnesses. Again, a great idea, except not in a pandemic. And so we are working with states, CTAC is working with states, and we know that states are working to try to remove those policy barriers as well. I could go on and on, but I won't. I will pass it on to the next speaker, and I look forward to your questions.
Thank you, Marion. Next up is Sarah Hooper, the Executive Director of the UCSF UC Hastings Consortium on Law, Science and Health Policy, and Adjunct Professor of Law at UC Hastings College of the Law.
Hi, I'm absolutely delighted to be here among these amazing women who are helping to advance these conversations about advanced care planning in such an important way, and really delighted to be here. Thank you CTAC and Petrie-Flom for hosting us. Marion started to chat a little bit about state level legal policy barriers, and I'm going to dive into those a little bit further. So as she said, the movement on the federal level has been really encouraging, particularly enabling providers and patients to have ACP conversations via telehealth and audio only telehealth. But unfortunately, on the whole, state level advanced planning law still doesn't recognize advanced directive completion in telehealth environments, or for that matter, post completion in telehealth environments. So providers and patients may find that they have really good conversations, but then run into barriers documenting them or be confused about, the legal validity of those conversations. And I think one sort of thing I always like to reiterate is that any statement by a patient with capacity about their wishes should be respected and followed. And the level of documentation is sort of a separate issue. But I just want to reiterate that the law supports recognizing statements of patients' wishes, no matter how documented. But to the extent patients and providers are trying to complete advanced directives, either the living will portion or the appointment of a power of attorney for healthcare, there are barriers that are in the law to actually doing that in telehealth environments. So the two main barriers are witnessing requirements and patient signature. And I'll start with patient signature. So the vast majority of states still require a physical signature by patients, only 4 states recognize digital signatures, and that's in California, Illinois, Maryland, and Texas. And those digital signatures have some authentication requirements around them that may pose challenges for people who may not have access to DocuSign. And you may be thinking, you know, don't we sign documents online all the time now? And of course you are right that we do, but federal and state legislation that recognizes e-signatures on things like contracts specifically exempts documents like advance directives and wills. So specific state action or even federal action would be required to address that gap. And in thinking about revising signature requirements, states should really be keeping those equity issues in mind. So many patients still only have access to landlines or may have physical disabilities that inhibit their ability to provide a physical signature. Currently, a majority of states allow patients to direct another person to sign on their behalf. And these are important accommodations to make sure everyone has a right to have their wishes recognized. And these should be expanded, should include documentation guidance for the person signing on their behalf, particularly if the person who's doing the documenting is doing it remotely. So the second type of barrier is witnessing requirements. All but 3 states require advance directives to be witnessed by at least 2 individuals. A majority of states require those witnesses to be in the presence of the patient while she signs, and almost all states restrict who can serve as a witness. So healthcare providers and certain individuals entitled to inherit from the patient are common exclusions. So this requirement of convening in person is obviously problematic during a pandemic when patients are advised to social distance or are required to do so. And additionally, this was a problem for some patients before COVID, where those patients might have narrow social networks and they simply don't have 2 qualifying witnesses in their life, or their witnesses for various reasons have difficulty convening to execute a document. Now, 23 states permit notarization in lieu of witnesses, which can sometimes provide an easier alternative, but most states don't recognize e-notarization. And notaries are required to meet the individual in person, see their identification, and physically stamp and sign their advance directive. And notarization services are not free, and so this can be a barrier to access for some patients. And then in addition to these kind of general witnessing and notary requirements, 13 states require the involvement of additional signatories. So for example, here in California, residents of long-term care facilities must also obtain the signature of a long-term care ombudsman. And of course, even long-term care ombudsmen are not being allowed into SNFs and assisted, other facilities around the state right now. So that's a barrier. So some states are working on this, which has been encouraging, and are trying to use governor's executive authority, which is triggered during the state of emergency, to temporarily ease these requirements. And New York was the first state to do so, allowing witnessing to be conducted via audiovisual means and providing protocols for how documents are exchanged and signed. And some states, many states actually, are temporarily recognizing e-notarization as another option. So these are all a good start, but really what is needed is a much broader effort to re-examine our state law around advanced care planning, think about whether these requirements are serving their intended goals. There's a lot of evidence that they're not. And think about how we can better encourage and support decision-making in what is undoubtedly going to be a telehealth world going forward. Thank you.
Thank you, Sarah. Wow, fantastic opening remarks. Thank you all. I just actually learned a lot myself. Be sure, everybody watching, to join the conversation on Twitter and ask your questions there or via the Q&A function on Zoom below. And we'll be starting to answer your questions pretty soon here. But I want to start in our continued conversation with Stephanie. So Marilyn, in her remarks, raised the importance of accountability as it relates to systemic racism that really pervades the healthcare system, medical education. This is such an important conversation. Will you give us an example of a strategy for accountability?
Yeah, thanks, Shoshana. It's a great question, and I thank Marilyn for elevating this issue. I'll answer from a two-part standpoint. From a national standpoint, looking at accrediting agencies such as the Joint Commission would be an excellent place to start. They have standards related to advanced care planning. None of the standards that I've seen include any anti-racism, any other components of what Marilyn so eloquently raised, especially around advanced care planning. And in fact, I think most of us in the advanced care planning world are really passionate about the idea that if you know an individual's preferences and you do not follow them, that should be considered a medical error or a patient safety issue. In fact, so many organizations that we work with, one of their priorities for implementing a quality advanced care planning program is to decrease patient safety error. Medical errors. And so heightening the accountability to improve the standards and create this as a patient safety issue would be one way to do that. From an individual, community, or organization standpoint, I'm actually going to use Gundersen Health System as an example. When they were doing this work 25 years ago, Dr. Jeff Thompson, the CEO at that time, created a medical staff compact and held all providers accountable to know what matters most to the individual before deciding on options to offer related to decision making or providing clinical care. And if a physician went directly against a known preference without a valid reason, it was considered a medical error and they were held accountable within the organization for that. And you could tie Marilyn's research that she talks about the implicit bias and tie that to that accountability and that education that the providers are receiving and have them go through simulation lab and hold them accountable to recognizing their own bias and setting it aside as they're providing a quality of care for all people. Thanks for the question.
Yeah, thank you. So Marilyn, you mentioned equitable education, communication, and then empowerment for all patients and their families. How do you see that, or how do you wish that that was going to be operationalized if it's not at this point?
Yes, thanks for that question. I would really love for it to be operationalized right now. And so as a researcher, I'm of course looking to see what research is out there that can help inform our practice, because I really believe that research can inform our practice no matter what our vocation is. And I know that there's a Duke University study that's going to be completed in July of 2022, reducing disparities in the quality of palliative care for older African Americans through improved advanced care planning. Amazing. And I'm really hopeful that this will give us some more insight into what the persons that we serve or desire to serve or to desire to provide care to, what education, communication, empowerment means to them. But until we get the research, I will offer these. That one, we engage persons we seek to offer care to in a space that they deem inviting and a space where they feel cared for. That we ask questions not to respond. And what I mean by that is that we ask the question with the goal of understanding and from a different perspective. So not trying to understand and to get them to come to what we think, where we think someone should be, but to meet people where they are and to understand that space, and then be able to ask questions such as, what would be helpful to help you understand medical information? Or would you prefer to have information either written, electronically, or via a video before your visit? And so when we ask and invite, we empower. And that opens a two-way street of communication and dialogue. When we are dictating, that is when we demean other people. And so I really feel that if we invite, then we can start to break down those barriers of communication to normalize advanced care planning, both for the clinician as well as for the patient and the person whom they're trusting to make healthcare decisions for them if they're unable to. Thank you.
Thank you. You know, in this new world of sort of flipping to telehealth, you know, Marion, a question for you. For me as a clinician, I actually use telehealth often, and obviously much more now during COVID. I have loved the new flexibility with these virtual patient visits that I'm able to do. So, you know, telehealth is also a great way to expand access to advanced care planning, of course. It comes with its inherent challenges, but what is your sense about whether any of these changes that have been put forth will be made permanent? Obviously, the timeline is unclear given that the timeline of COVID continues to remain uncertain, but do you get the sense that, you know, this is all here to stay?
You know, thank you. I do think all of us recognize that time is not only come for telehealth, it's overdue. And we know that the CMS administrator, Seema Verma, has already said on multiple occasions that they are going to look at making some of these things permanent. CMS just issued a few weeks ago the proposed rule for home health for next year that already does make some of these changes permanent. Of course, I wish we could wave a magic wand and just keep everything. I think we have to recognize, and actually the Office of Inspector General, the OIG, is going to be taking a look at potential fraud and abuse, unfortunately, with advanced care planning, because much as I love the idea of being able to call people on the phone, I could bill left and right for that, right? And I have no proof as a clinician that that didn't happen, because I don't have to have documents that come out of it. I just need to leave a note that says I talked with Mrs. Smith and we agreed on the following. And I think that everyone is a little bit nervous with telehealth that I mean, it really could open up the opportunity for significant abuse and fraud. And so I think that's why it's so important that we use this current experience. And I think there are now 1 million or more telehealth interactions every week going on during the pandemic. So that is a lot of data. I think that we have to use this as a way to figure out, okay, what was inappropriate in that? And what do we have to fix via regulation to minimize the opportunity for fraud or abuse going forward? But I think the fact that people will be able to do this from home, I think, is a given. I mean, if we change nothing else, I think that will have been a significant change.
Yeah. Well, so several people have asked in the chat, or rather in the Q&A, and again, folks, if you have questions, be sure to ask them via Twitter or the Q&A function below. Several people have asked, in terms of reimbursement for advanced care planning, and I guess this is a question maybe for Marion, but if other people want to jump in as well, that'd be great. Will chaplains also be considered for reimbursement? We've talked a little bit about different levels of training and people, there being more flexibility potentially about other clinical staff who should be having these conversations. Could expanding reimbursement for advanced care planning to even community health workers help eradicate advanced care planning disparities? That was another question that came through. Would that allow health systems to employ people on the ground? And who else should be reimbursed for these kinds of conversations?
So I think those are excellent questions. And as a nurse practitioner, I'm lucky, I guess, that I'm in the select group that can already do this. And believe me, having been a nurse practitioner for many years, it took us a long time to get there. I think we have to recognize that who has the conversations is not the same thing as who gets reimbursed. And reimbursement is going to be hard. Just again, because I don't think Medicare reimburses chaplains for anything right now. They don't have NTI or NPI numbers. I mean, there is no mechanism to do that. And I think that also when Medicare looks at expanding the number of people who can do something, they look at the cost. So while we would all agree that expanding access to advanced care planning is important, they have a certain amount of money budgeted at Medicare to do that. And if you all of a sudden allowed everybody who could potentially do it on the team, and I totally agree, RNs, community health workers, LPNs, I mean, you know, there are many people who could have very effective and are having very effective conversations that are advanced care planning. But I think that it's the moment you start opening the door, it greatly would expand the cost of advanced care planning. So I think Medicare is going to have to look at, okay, who already is reimbursed for some things in Medicare? Let's maybe expand to that, and let's monitor how this goes and see if we can figure out how to get to the rest. You know, I would not let reimbursement discourage people from advocating with their organizations to be the one having these conversations. Even before I was a nurse practitioner, I was better at this than many of the physicians I worked with, and I don't mean to brag. It's just kind of a thing nurses are trained to do, right? So I mean, having these kinds of conversations. So I totally agree, chaplain colleagues, I am doing what I can, but I will be happy if we can get social workers and case managers in, because they already bill for some things with Medicare.
Thank you, Marion. Sarah, question for you. So you're an expert on state level barriers that exist. How can individual state level advanced care planning policy better address the needs of underserved communities?
Yeah, it's a great question. So I think one of the issues that we've seen pre-COVID, and is not even necessarily a telehealth issue, is the issue of mandatory language and health literacy. So a lot of these advanced directive documents and the statutory forms were developed by lawyers. And I'd say as lawyers, we're not good at end user testing. So they're written at a very high literacy level in legalese. And so if our goal in advanced care planning is to elicit in a very open and inviting way patient goals and preferences, and then communicate those effectively across, you know, the vast range of stakeholders within healthcare systems, we need to have language that does that and is accessible to the broadest range of people. We know that the US population as a whole reads at about an 8th grade reading level, and the elderly and Medicaid populations read at about a 5th grade reading level. So tools that can more effectively communicate with these audiences and can also be more easily translated into multiple languages, I think will help address some of those barriers. The other thing that states could do is think about recognizing non-Western views on decision-making. So about 20% of people don't want to make their own decisions. A lot of people would like to defer to group decision-making. The Uniform Law Commission is currently looking at these issues and looking at potentially making some revisions to the model statutes that states could elect to follow. So these would be some important reforms to think about that would be more inclusive.
Thank you, Sarah. You know, so we've had a few questions specifically come in about engaging younger people in conversation. I said we're never too young to engage in advanced care planning. However, you know, young adults remain a population that's often, you know, overlooked in terms of this type of discussion and frankly unengaged in this process. So this is a question for any of you. But what steps can be taken to specifically reach a younger population? And do you think that the steps to engage young adults in advanced care planning or the strategy should look different than the targeted outreach for older adults? Is anybody working on this?
Yeah, I would love to jump into this first and have my colleagues contribute. So I have 2 boys, and when they became adult age, I had to bribe them to get them to have an advanced care planning conversation with me, and it worked. I asked them for 15 minutes, and it lasted 2.5 hours and was one of the most profound conversations of our life, of our family history. And the way that I engaged them was not talking about, if you have a chronic illness someday, what does that look like? What are you going to want? But you had a friend that was in a car accident from texting last year, and now you're both adults. You have to think about who would make decisions for you if you were in the hospital after a car accident for a week. Even if you're not dying, but you are unable to make your decisions. What if you have a permanent brain injury? Will your goals of care change if that happens? What does that look like for you? Who do you want to be your decision maker? So engaging younger populations really does need to look different in social media, use of technology, you know, that what these folks are accustomed to and how they're engaging and everything else, and normalizing this as a part of routine healthcare, preventative medicine, I think is critically important. It's inappropriate to ask a younger adult what their goals would be if they have stage 4 cancer, right? And so making it relevant to them. And as Marilyn said, asking. And with younger people, we tend to anticipate their response and already know what we think about it. Asking and just listening and understanding where they're at, and provide incentives to get them to do this. A group a conversation might be really appropriate. Finding a group of you know, Eagle Scouts in a setting and bringing this to them. So where they're at, where they're working, where they're playing, where they're worshiping in the community, taking it to them. A faith community would be another example to engage a youth group in this kind of strategy. So anyone else, colleagues, that you'd like to add?
I think we should make it an Eagle Scout badge.
There you go. Marilyn?
Yes, so as a parent of a student who is about to go back to college, I have been thinking about the soccer team has all these team meetings. At one of those team meetings to talk about advanced care planning and just to talk about what it is in the context of if you're on the soccer field, you have a soccer injury, you're unable to speak for yourself, who do you trust? And what would you want them to say on your behalf? As Stephanie said, to bring it into their context. And I do have great concern about, of course, my son has.
Oh, I think Marilyn may have froze there. Hopefully you all can still hear me. Yeah, and I have, you know, seen
their bill.
Oh, she's back. Okay.
Oh, did I freeze?
We had you freeze for a minute.
So I'm looking on how we can actually normalize it and how do we bring it into their context and just make it a conversation that is casual, that gets them to thinking about advanced care planning, and then being able to communicate that to someone that they trust.
One of our viewers said that advanced care planning can be a great conversation for pregnant women and new families as part of their family planning process. I know I've seen a couple of San Francisco-based clinicians go into high schools and teach courses on more about, in general, kind of mortality education, but it absolutely gets into conversations around advanced care planning, even for teenagers. So, you know, so important to start early and to normalize these conversations.
I think COVID gives us, unfortunately, an opportunity, because it is not impossible, although unlikely, I'll acknowledge it. It's not impossible that a young person could get COVID and could quickly become unable to speak for themselves. Though that does happen. And so it seems to me that as you're talking about social distancing and wearing masks and kind of preparing for what would you do if you got really sick, that this would be a lovely time to turn to the young people in your life and say, oh, by the way, if we have to intubate you, like, is that okay? And is it okay if mom and dad or your sister or whoever, it speaks for you? Because this is not, I've had a 29-year-old patient in one of my ICUs at my hospital. He was there for like 8 weeks, entirely unable to speak for himself, on a ventilator, on all the high-tech stuff. And he finally got better. But while he was in that situation, someone in his family had to speak for him. And when I spoke to the family, they said, of course, we never discussed this, right? But now I think it's a good reason to discuss it now.
Absolutely. Another question from the audience, or first a comment. One of the reasons I think people gravitate toward a focus on documents rather than conversations is that it's much easier to count and measure documents rather than conversations. So I believe it was Stephanie that talked about this. What are the best examples you've seen of organizations measuring quality conversations as the outcome or the metric rather than just the documents? And this can be for anybody as well.
Yeah, thanks. It's an excellent question, and it has been a focus. And moving the focus to the measurement of conversations accomplishes many things. First and foremost, elevating the importance of the conversation, right? One of the strategies that I would suggest is defining what you mean by a conversation. So that way your measurement of the conversation is consistent. And we've worked with a lot of organizations that have defined it in different ways. So you measure different types of conversations. It might be a 4-minute conversation that a provider has in a clinic introducing somebody to advanced care planning and the concept, and giving them a card that is about the role of your healthcare agent to start thinking about your agent. That would be probably counted as a contact. And then the individual has a follow-up conversation to help them think about who their decision maker is. Might be a 10-minute conversation that's defined. And then you may have a more robust conversation where the decision maker and individual are together talking about goals and values and treatment preferences, and you might classify that. So that's a pretty extensive example of how the conversations can look differently and be measured differently. Of course, we all have data and measurement burnout and are overwhelmed. So building it into any current systems that you have to be able to collect that information tied to documentation of the conversation. That would be the best way to likely capture that information. It can't not be hidden in a progress note by a chaplain from a visit they made on an inpatient unit, right? So leveraging your EHR, other technology solutions to make documenting the conversation and accessing that information and querying it for data as easy and accessible as possible is key to that. We would never say not to count the number of documents, but remember they're voluntary. And as Sarah so eloquently said, anything that somebody presents that tells us what their goals and values and preferences are, we need to respect that. So it really is pretty restricting to only rely on counting documents.
Yeah, I would just add that from a medical legal perspective, we convened a group of experts last year to think about, from a documentation perspective, what is actually the most important piece. And I think what everyone sort of agreed was that the appointment of a healthcare agent is the single most important piece from the perspective of documentation. The goals and preferences and wishes we hope and expect will evolve over time and can come in a variety of forms, and that's sort of like the meat of the conversation. But in terms of patients who are trying to navigate across multiple systems of care, having a duly appointed healthcare agent who can be recognized across all of those settings and not just relying on default agents or oral appointments, which are only good in particular settings, is really important for a lot of people, particularly if they're cycling through long-term care settings as well.
Yeah, and I would say that in this regard, from a policy standpoint, a federal policy standpoint, Medicare is ahead of us because they don't require documents to be able to be reimbursed for a conversation. They are reimbursing the conversation. Now, the quality of that is a separate issue. And I think to Stephanie's point, there is great opportunity there, no doubt. But you can, as one of the 3 providers who can be reimbursed for the conversation, you can be reimbursed in half-hour increments, and there don't have to be any, it doesn't have to be a signed advance directive come out of it. There just has to be some note in the chart that confirms that a conversation was had and what was discussed and any decisions that were made, if any were made. So I could have a conversation with somebody for 25 minutes about the idea of advanced care planning and choosing a healthcare agent. That person might say, I have to think about that. I could still be reimbursed for that conversation. And obviously there's follow-up required.
Following up on what Sarah said about identifying a person, who do I trust to make healthcare decisions for me? I agree. Having that person that has been identified is very important. The other component of that is that that person understands how they're honoring the person that has named them, right? And so if we don't have that conversation and they don't fully understand, or it's not written in a document that they have access to, then we run into being at the bedside with a person who has been named but doesn't know what to say. And that is a very traumatic experience. So at AdvocateAuroraHealth, we say we ask, we understand, we honor. And so we ask, who do you trust? What do you trust them to say? And then we honor that. And so I think when we're talking about what's the quality of the conversation, what do we consider a conversation? How do we, does a document count? To Sarah's point, having that person named counts, and then they need to know how to honor their loved one.
Thank
And
you.
then I would add to that, just building on what Marilyn just said, we would call that avoidable suffering. We suffer when we grieve, but we can avoid the suffering that comes with being a decision maker and not having a clue what decision to make. That increase, and there's research that increases stress, that increases anxiety, complicated grief responses. That suffering can be avoided. It fractures families. I had an individual tell me he had had quality conversations with his dad. His brother hadn't, came in and accused him of murdering his dad when he put him on hospice. And so we can prevent that fractured family, all of that avoidable suffering by having these conversations, appointing the agent, preparing them, and documenting. And that's the system that needs to be redesigned that I talked about in my opening remarks, that none of this just happens without intention and without system redesign.
Thank you. Another, along these same lines, another question, this person asks, I'm from a low-income religious Latinx community. A lot of advanced care planning conversations stay between parent and child. So I assume that they mean that it's just, within the home. How are advanced care planning rules about patients' word of mouth end of life desires handled, and how, and then the further part of the question is, how are they treated differently from patients' word of mouth about their things like their assets or that kind of thing? But I think getting more toward this kind of conversation that's had within a family, it's discussed, and then this question of maybe lack of documentation, or how do we think about that? And for communities that are used to maybe, or feel more comfortable discussing that within family members, how do we make sure that that information gets to the right people at the right time?
So there's nothing prohibiting individuals from sharing information with family members and others. I think they are reluctant to do it because it's difficult to talk about. But one of the attorney experts we worked with on our panel last year had a great phrase that cracked me up. She said, make the advance directive and then spread it around like manure. And basically the idea is, this is the one piece of healthcare that we actually would like to be advertised broadly to everyone's social network and family, so that everyone, as Marilyn and Marion and Stephanie have said, that caregivers and families feel prepared for the decision when it comes, and then it doesn't hit them as a surprise. We have surveys that indicate that patients are still vastly more likely to complete advance directives with lawyers. About 46 to 76% of patients in a couple of studies we have say that they completed advance directives with lawyers versus about 6% with physicians. And as attorneys, advance directives are still part of estate planning, and those documents are considered to be protected by attorney-client confidentiality and are often put in a box somewhere and not shared with others. So one of the things that we're starting to do is recommend to attorneys, figure out how to interface and help your clients actually share this information with their healthcare providers, with their family members. It's obviously, if they wish to keep it private, it is obviously their right to maintain privacy around that. But I think it's important for us as advocates to recognize that we're doing our clients a disservice if we're not educating them about why it is that it's important that, you know, others have information and access to these documents.
I completely agree with that, Sarah, and I would just add really quickly that we shouldn't expect anybody to conform to our box, right? And so if this family is having these beautiful conversations within their family, that's absolutely wonderful. Let's support that in any way we can. I was working with a Hmong patient, and they completely did not believe in completing a legal document of any kind. So they wrote a letter to their doctor expressing their wishes, and we should accept that and be able to store that and transfer that. And then I think you're exactly right, Sarah. We have to help them understand the potential unintended consequences if they don't want to communicate. So everybody in their family may know each other's wishes, but if something happens to grandpa and none of the family can be reached, they need to understand that full medical treatment, best medical practice will be the care that he receives. And so at least they understand that, and they may or may not agree with that, but without that understanding, then we're doing them a disservice, I think, to having all the knowledge they need in that situation.
I agree. Trust comes into place, right? So if we're saying you need to understand that this is what's going to happen, can I trust you when you're communicating with me? And so I can't stress enough the power of trust being a two-way street. Are we exhibiting the behavior that makes us someone that people can trust? And how we respond, again, to hear and understand versus, as Stephanie said, to here's the box, I'm trying to get you to come into this box, versus being open to the other options. And I know in our vocation, we're like, we have so much information, but we have to remember others don't have that information. And so we have to meet them where they are and come alongside in the space.
Switching gears a little bit in terms of thinking about training around having these conversations within the healthcare setting. We know from a 2016 study from the Journal of the American Medical Association that when surveyed, 70%, that's 70% of practicing clinicians said they had not been trained in sort of how to have difficult conversations with patients, which to me as a physician is shocking, but it's, I think it's changing slowly. But a question from the audience here, what does the panel think about increasing such training related to effective communication and advanced care planning nationwide, and mandating this in medical schools and nursing schools?
Well, as somebody who's used to be fully on faculty, now adjunct, there's a lot of stuff that we need to teach physicians and nurses. So I know it sounds like a great idea to mandate things, but there is a ton of stuff that already has to be taught. But I think one of the benefits of, again, the COVID pandemic is I think a lot of clinicians have realized, oh, I don't know how to have some of these conversations. And I know as a practicing palliative care person, our team and other teams around the country were in great people reached out to us to help have those conversations, because it started to become really clear, okay, wait a minute, somebody might not have a good outcome. How do I help the family? Because often the patient was too sick. How do I help the family come to grips with that? And I am hoping that coming out of this, that there will be a broader recognition that advanced care, it's just one of many things that clinicians need to be better at. And I think to Marilyn's point, we're not very good at inviting. We have a standard list of questions we ask, and we train you as a patient to how to answer them. We don't deviate, and you don't either. And that is a problem, because we don't get a lot of information that we should get even beyond advanced care planning. And when I taught at the university, at University of Maryland, one of the things that I taught was communication to young nursing students, or to new nursing students, because it is the fundamental thing, I think, of good medical and clinical practice. So I think it's important to teach people how to have conversations in general, and this in specific as well.
I would agree. Establishing education that supports development of competency around core communication skills that are transferable and applicable across all that we do. I even use them with my cat sometimes. They become so inherent to me. And then added the layer on based on your role and what your responsibilities are, appropriate education for what you're expected to do so you can do it well. Not only increases competency, but really we are finding through experiential evidence increases satisfaction, decreases burnout, decreases moral distress in having these conversations. But again, I'll sound like a broken record. We started at Respecting Choices by offering education, and it quickly became clear that education alone wasn't enough. You can have the most beautiful, skilled conversations if you don't have the system to support it, to create real change and move that forward. So tying that together, it would be the recommendation that we'd have: education and system redesign.
Absolutely.
And I would say to engage your resources. So we know that physicians don't tend to be inviting, and so, but chaplains are inviting. And so it could be a team approach of advanced care planning. And we know that each of us as an individual clinician can't do everything and can't be everywhere. And that's why we have partners in the interdisciplinary team. So to leverage a chaplain, a social worker, a care manager for having these conversations, I believe is where we need to go, and to ensure that we understand who we are coming alongside, and to understand values and cultural competency and emotional intelligence. That's what chaplains do.
Thank you, Marilyn. Yeah, absolutely. The team is where it's at for sure. Another audience question, changing gears a little bit, is there research on advanced care planning in the LGBTQ community? And have any of the panelists seen this addressed or want to speak to some of the barriers or obstacles that exist?
I guess I'll start by saying that the law for many years was a barrier. Luckily, now that we have constitutional recognition of same-sex marriage, those barriers have been reduced somewhat, but there is still work to do on the state level to recognize, for instance, people who don't choose to get married but have a same-sex partner are in sort of non-traditional family structures. And so I think those are some structural barriers on the legal and policy level that we can and should address, and I think are being examined at the state level right now.
Thank you, Sarah. Another audience question, and really important given the disease burden in this country of dementia. So how is advanced care planning different for patients with dementia? And now, of course, that can be, depending on the stage, highly nuanced, but how should it be made better? And then are there any sort of legal obstacles around advanced care planning?
So, I think this is a wonderful example of why anticipatory planning is so important. I'm very frustrated in my wonderful cancer center that I meet patients who've had 2 years of oncology treatment for metastatic cancer, and yet they've never had that conversation. I'm like, how can that be? Mm-hmm. So I think where we know that there are certain illnesses that are going to progress, intervening early, and this is actually something that on the federal level that Medicare has now provided a number of incentives and requires in a number of their Medicare programs that these conversations do occur with people who have been diagnosed with dementia, but do it early enough while they can fully participate. And I mean, even somebody who is moderately demented can possibly speak for themselves, has enough understanding of what they're agreeing to or not agreeing to. And there are processes in the hospital to try to confirm that. But I think it's a good example of why this should be something that's done well in advance when the person can speak for themselves, and then needs to be honored. And that is always the tricky part, because sometimes people say, if I get to the point where I can't eat, I don't want a feeding tube. And yet when the person gets to that point and can no longer participate, it's hard for the family to say, okay, I guess we're not going to do that.
And I would add to that, well said, Mary, and I would add to that, if we miss the opportunity for anticipatory planning, having people understand how to have the conversation with the decision maker, and reflecting on, let's put your mom's picture in the room with us and she's not able to participate. And let's think about this conversation from what was important to her, what mattered most to her. I understand you love your mom very much. The decisions you might make for her may be different than decisions she would have made for herself. So ensuring the person with dementia's voice is the loudest one in the room when you're having these conversations is really important.
Yeah,
Thank
just
you.
amplifying Stephanie's comment. I mean, I think, and this is related to training about and communication. I think training in understanding the nuances of capacity and how that is not an all or nothing thing, and increasingly in the law is recognized as not an all or nothing thing, I think is really important, along with concepts of supported decision making and how individuals with dementia can be engaged in decision making throughout stages of illness, I think is really important, but I think is a big gap in training. And we know that there's a huge need for providers to be able to work effectively with older adults and to tell sort of when someone is truly facing a cognitive barrier and when there may be other things at play like loss of hearing, medications, those kinds of things, or language barriers that are the issue, or their communication style, and how can we address those to better involve patients with dementia.
Thank you all so much. We've reached the end of our conversation today. So I want to thank all of our panelists, Stephanie Anderson, Marilyn Barnes, Marion Grant, and Sarah Hooper, for this wonderful conversation. We had such an engaged audience, and you guys maybe didn't see this, but there's really positive, thoughtful comments and questions. So thank you all so much for participating. Thank you to the Petrie-Flom Center, as well as CTAC for hosting this conversation today. I believe a recording will be made available. A few people did ask about that. And just thank you all for joining. It's conversations like this, that give me a lot of hope and encouragement in these rather tough times. And I just thank you all for your amazing work.